Ladies and gentlemen, it gives me great pleasure to welcome all of you in webinar number 34, Minimally Invasive Endoscopic Spine Surgery, among the series of webinars organized by the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies, the CNS. First of all, I would like to express my sincere appreciation to all our distinguished speakers. Dr. Sigdam Bumko, she's a neurosurgical specialist, Sultana State Hospital, Istanbul, Turkey. Dr. Henry Demeno, he is working in the Capital Medical Center in Philippines. Dr. Omar Youssef, professor of neurosurgery at Ain Shams University, Egypt, will join us later. Malcolm Pistonji is from Mumbai, India. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time, sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. To all attendees, we are glad to get your questions and comments, and this will be monitored through the chat panel or the Q&A. I think now it's time to start the webinar. Our first speaker will be Dr. Henry Demeno from Philippines. Welcome, Henry, and thank you for contribution to this webinar.
Yes, thank you very much, sir. I shall share my screen now. PowerPoint. I chose this topic because I'm actually one of the younger, if not one of the youngest spine endoscopists. I only started in 2019, so I hope this is useful for a lot of the other young surgeons like myself. Okay, if I may start, I would just like to introduce my journey to getting spine endoscopy. Just a quick one. I was actually first in love with neurosurgery. I'm an orthopedic surgeon, but my first love was neurosurgery. I graduated medicine in 1999 in the UT College of Medicine in Manila, and I applied in the neurosurgical residency. I was accepted in Philippine General Hospital. It's a government hospital. It's a training hospital of my med school. In the Philippines, when you say government hospital, it usually means that the patients are charity patients. The patients who cannot afford private care will go to government centers or government hospitals to get treated because they don't have enough money to go to a private hospital. And this was very challenging, how to do neurosurgical work or any kind of surgical work. If your patients cannot spend much, there's always competition for the operating rooms, for all the resources, the CT scans, the MRI scanners, materials, even manpower. So I decided to leave neurosurgery. I resigned my post and I said I wanted to go to a private hospital. I went into the medical city the next year and I shifted first to general surgery because I wanted to figure out where will I go next. During this time, I met this guy over here, Dr. Tony Rivera. We consider him in the Philippines as the father of sports orthopedics. He's an arthroscopist. He brought knee arthroscopy and ACL surgery to the Philippines. And he was also working in Medical City. He recruited me to be an orthopedic surgeon 3 years later in Makati Medical Center. The department head in Makati Medical Center was this guy, Dr. Ramon Bustillo. The orthopedic people in the audience will probably know his name because he's very famous in orthopedics. So after 3 years in general surgery, I decided to go to orthopedics, and I graduated in 2007, and I did training starting 2019 with another senior, Dr. Richard Condor, who taught me spine instrumentation. I was his junior consultant for about 3 years. So my introduction to spine surgery was really for fusion. This is me doing surgeries. It's actually the surgery of my father in 2018. See what else. My first exposure to endoscopy came in 2019, a whole decade later, to Dr. Daejun Choi from Korea. He came to the Philippines to do a cadaver workshop, and he showed us biportal endoscopy. That was my first exposure to it. And I was so fascinated by it, and I was wondering, why don't we have this in the Philippines? Or why are there only very few people who do this kind of surgery? So my interest grew, and in that same year, it so happened that the fifth ASEAN MISST Congress was in the Philippines. I don't know if I met any of you there. And then all the more that my interest got even bigger for this field. It led me to seek training with Dr. Cholwong Park in South Korea, December 2019. I went home February in 2020 because of the pandemic. I would have wanted to come back to Korea or to extend my training. Hopefully, I'll be able to go back to Dr. Park and train some more because he's been inviting me to go back there. Also on the side, I would just like to mention that I actually teach in med school. I was teaching from 2019 to 2009 to 2019 in one of our university's med schools. But I had to resign because of clinical work. I couldn't devote enough time to teaching anymore. Okay, that said, I would like to say what I will not be tackling in this lecture. I will not tackle with technical aspects of doing the surgeries. There are so many more experienced doctors in the panel who can give more information and teach better than myself. I will not be going into indications either. Again, there are so many of you who know a lot more and a lot better than I do. Uh, I will maybe mention a bit for those for the newcomers. I will mention a bit of the risk benefits, and for those who are non-spine or who are not in the fields of neurosurgery or orthopedic surgery. I will not comment on instrumented fusion. I guess that, again, that's another technical talk that somebody else will be better equipped to deal with. What I would like to talk about would be hacks or certain tricks that maybe the newcomer can do, a newbie endoscopist like myself. I would like to share my experiences as a beginner in terms of sharpening skills, especially between surgeries, because there aren't that many surgeries being done right now, especially for in my case in the Philippines, we're still dealing with this COVID crisis until now. One of the challenges for me as a beginning endoscopist is how do you make your hospital capable of doing the surgery when they've never seen a spine endoscopy at all? So that's a very big challenge. And again, why and spine endoscopy services are useful in this particular time now more than ever. Okay, when I say newbie or a beginner, I mean a surgeon who has already finished residency training, knows the basics of spine surgery and hopefully spine endoscopy, and is starting to practice. So we're not dealing with the residents here. Okay, next. I just want to define what I mean by hack. The classic meaning is to chop something off, like chop wood or to chop a branch with a heavy tool, like an axe. In modern parlance, we know of hacking as it applies to computers. You want to hack a phone, hack a computer, hack an account. But I prefer to think of hack as being able to manage or to cope or to adapt to a particular situation, being able to go around the problem or an obstacle, or being able to find alternative solutions to a difficult problem. So that for me is the most practical application of a hack. And if you think about it, for endoscopic spine, we came from open surgery, midline approach, a lot of muscle trauma, a big wound, a lot of bones removed, ligaments removed. And then we progressed to smaller and smaller openings to paracentral approaches, Wilsey approach. And then, of course, the tubular retractor technology was introduced. This is my dad in 2008, 8 years prior to the fusion. And from here, now we have endoscopy, which up until 2018, I had never actually seen. And so if you think about it from coming from here to here, it's a whole series of hacks, a whole series of improvements in the technology, in the techniques, in the doctors themselves. And now we have biportal surgery, which you're using a scope that is traditionally used for the knee. So when I first heard this, I was so amazed that you can actually do that. I did not know you could do that. Okay, so that's what got me interested. And moving forward, I would like to at least encourage the young surgeons like myself or even younger surgeons to consider, if you're doing spine surgery, consider endoscopy. Maybe you would like to switch. Learn what you can, but learn this also. So why? Of course, there are benefits to the patient. There's a patient of mine about 2 hours after spine endoscopy, a biportal procedure. She's already smiling. She's already sitting up. So that's a very big plus. I mean, have you ever seen a fusion patient that was smiling immediately after surgery? Okay. There is, of course, as we know, reduced risk of introducing instability because of the surgical technique. There is reduced risk of adjacent disc disease. is a patient of mine 4 years later. I did the fusion. The adjacent disc is already bulging. There's already hypertrophy of the ligaments of flavum. He's complaining of new symptoms now. So I'll probably do endoscopy on him. There is, of course, for the Philippines, as I said, the difference between private and government patients. There is reduced cost of care. There is, of course, less pain after surgery, faster recovery time, better healing. The patients are happier. And of course, it's peace of mind for the patient. I can spend less and still heal faster and avoid long-term problems or possible problems along the way. So that for the patient is something major, especially here in my setting in the Philippines. But what about benefits to the doctor or to some limited extent to the medical staff? Well, one of the things that I really am thankful for endoscopic surgery is the visualization. You can zoom in on what you want. It's a posterior cervical foraminotomy that I did, and this is actually still a nerve, C6 nerve root, motor branch. That's the herniated disc. I'm cauterizing around it. Now I'm trying to imagine what would that have looked like if I was doing it maybe using a microscope, an operative microscope versus an endoscope. So that's a very big jump in terms of the evolution of the technology. You can zoom in, you can direct the camera where you want, you can go places where you've never gone before. Okay. Another benefit for us is, of course, me as a doctor. One of my biggest problems is when a patient says, "I still don't have the money. If you're doing fusion for me, I need to raise the money in order to buy the implants, in order to spend for the hospitalization." So this is a big hindrance for me as a surgeon because now I'm waiting for the patient. The patient is waiting to raise money, and we can't do the surgery outright. If the surgery, if the treatment that I would be doing was very affordable, then the patient would probably say, "Yeah, that fits my budget. I can have the surgery done." But because of the financial constraints, patients in the Philippines, most of them anyway, will have to raise the money first before finally deciding to get treated. You can I hope relate to this frustration of mine. There is, of course, for me as a surgeon, the fact that there are decreased complications, not the patients are happier. This is a lot better for me, and so it leads to my peace of mind as a surgeon. If my patient has peace of mind, so do I. If my patients are happier, the results are better, and I'm doing less work, less wound opening, less wound management, less pain control, faster PT, everything. The patient goes back to normal in a shorter amount of time. So this is all a plus for both the patient and the medical staff and the doctor. The shorter hospital stay, especially in this day and age of COVID, is also a plus because you don't want increased contact times between people, medical staff, patients, relatives. You would rather keep contact time at a minimum so that you don't increase the risk of infection. Okay, so that being said, I would like to share some of activities or some endeavors that you could do, or if you're a beginner, if you're starting to do spine endoscopy, that will probably help you become more confident in what you're doing. Obviously, uh, the rule here is that if you want to get better, you should keep doing surgeries, more and more surgeries. But what if you are somehow prevented from doing a lot of surgeries because of the current situation, or because you're just starting and you're not getting that many referrals just yet? So here are a few possible tricks that I could share. Uh, in this day and age of digital media, it's easy to study CT scans, MRI scans, and luckily in the community of spine endoscopists, a lot of us share our experiences, share our the pictures, the videos that we get, and this whole cross sharing has been a very big advantage because we can see what the patient looked like before surgery, what it looks like after surgery, how the surgeon did the particular procedure. It is very very powerful. It's a very powerful teaching tool. The fact that we can share this information readily nowadays. Okay, so that's the first. Just because it's not your patient doesn't mean you can't learn something from the diagnostic workup of the patient before and after surgery. Another thing, this is, I guess, this will apply more for some of the orthopedic people. But if you're a neurosurgeon, you can always do injections, for instance, percutaneous uroscopic procedures of the spine. We just have the benefit for us in orthopedics. We have the benefit of still being able to use the fluoroscope for fixing bone and joint. I still do trauma surgery. I do a lot of trauma surgery, particularly percutaneous surgeries under blocks, day surgery. So I use that opportunity to keep acquainted with how to do directional control, how to read the image, the video while applying my implant, so on and so forth. So in the case of doing injections for the spine, if you're doing percutaneous injections, facet joint blocks, that's also very good. You get trained with the fluoroscope. Another thing that probably not many surgeons are into, any kind of surgeons, is ultrasound. I discovered this mainly from the anesthesia side of practice, regional anesthesia. Knowing how to handle an ultrasound probe and how to read anatomy, using the ultrasound is a very good addition if you're trying to learn anatomy and at the same time learn the muscle control, the technique in using both hands and looking at the screen. If you know the anatomy of the spine and you look at it under the ultrasound, and at first it will look strange, but eventually you will start making sense of it, and then you'll realize that okay, this is about the same thing that my endoscope does when my endoscope goes into the patient's back. So it's a very good adjunct. It's a very good help for you to learn. You're not doing spine surgery yet, and yet you're learning something that you can use for doing endoscopic spine surgery. Another thing, of course, again, because I'm an orthopedic doctor and I still have access to this, is doing arthroscopy because that's where I started using the scope for joints for the knee. If you have ortho friends, if you're a neurosurgical practitioner and you'd like to try first and you're still not feeling confident, maybe you can join an ortho body and ask for help in handling the scope and handling an instrument or a probe because the knee is very easy to scope. If it's big, there's a lot of space. There's nothing dangerous to hit in there. So you're not in under any pressure in the same way that you would be if you were looking in at the spinal cord or at the nerve. So it's good practice. It's nice help again. Now all of these would actually be training for you to use both hands while looking at a monitor. So all of these activities actually train you to develop the muscle memory wherein you're not looking at your hand and you're looking at somewhere else, and yet you're still coordinating everything. So if you incorporate this in practice, if you're starting, it actually raises your confidence level and your proficiency. Okay, this is something I got from Dr. Gustilo. You should learn how to draw. It doesn't matter if you don't draw that nicely, but at least do the drawing. The idea is if you can draw it, then you know it. And I guess a lot of you will agree because a lot of the spine endoscopists I've met online and in person know how to draw, know how to illustrate, and know how to use anatomic drawings. So this is not a strange concept. I encourage people, young residents, for instance, and students too. If you're doing the OR Tech, draw. I still do my own OR Techs and I still draw in the OR Tech. More so if it's more complicated. So it's a good thing. I'm very proud of the fact that I've progressed from line drawing to something like this. I actually draw for some of the doctors. I like doing it. It helps me with the anatomy. It helps me make sense of it. So if you observe well, you can draw well, and if you can draw well, you can teach it to other people, and the knowledge stays with you. It's a very good tool. Next thing, this is I guess it's very common now to video document our procedures, especially now that online teaching is very prevalent. But here in the Philippines, a lot of doctors still don't document their operations using electronic video. I don't know why. Some I guess are scared of doing it, and more so editing the video and presenting it to the patient. I've actually run into resistance with this because some doctors think that this is not a good idea. But I think as doctors, we do better if we teach and empower our patients. And at the same time, when doing that, we can teach ourselves, teach our students and our colleagues. And because of that, we learn better. So you learn what you want to teach, but when you start teaching, it encourages you to learn more, to learn better as well. This is a patient of mine whom I did an ACDF on cervical surgery. One day prior, I'm showing him the video of his surgery, which I've edited, and he's actually happy that he can see what went on during the surgery. The patients appreciate the fact that they know what went on and what's going on in there. And they actually, if you ask them, they will give you the permission to, yeah, go ahead and record the surgery. And after you show them the video, if you ask them, can I share this with my colleagues or can I put this on my social media as a teaching tool, they will also agree to that for as long as you respect their privacy, their anonymity. It's not a big issue. And I tell this to the young doctors always and to medical students that remember we're doctors. If you know the derivation of the term doctor, it literally means to teach. So how can you be a doctor and not want to teach? Okay, this is a patient whom this is just an orthopedic patient. Clavicle fracture, I did the pinning, local anesthesia, clavipectoral block, and he went home thereafter. And I said, can I feature your video on my YouTube page? And he said, yeah, go ahead, doc. And then just even before I put the video on, he posts on his Facebook, telling people about surgery. A lot of my patients do this, and a lot of patients in the Philippines do this because we're very we're very oriented towards Facebook, towards social media in the Philippines. But a lot of doctors fear about data privacy, and I keep telling them, well, you protect the privacy of your patient and you respect the patient's privacy. You ask permission when you have to, but of course, if the patient wants to reveal his identity, that's okay. It's his body. It's his decision to do that. If the patient gives you permission to present something, observe the anonymity, but at least the patient said yes. A lot of doctors are very paranoid about possibly violating data privacy. When in fact, all you have to really do is, be communicate with your patient. Make sure that your patient understands your motives and what you're going to do and why you're doing it. And they will normally say yes if you ask them well. So this is not really a major issue. So therein you share your discoveries, breakthroughs, and innovations. And in endoscopy, there are a lot of innovations happening, and we see them being shared on the internet, in our own doctor groups. And this is very helpful. I've learned so much from the sharings of other doctors, other more experienced people who are not who are not limited to just sharing things face to face, and who document their cases and who actually want to teach other people. This is my YouTube page is an example of what I curate, and I know that a lot of other doctors also compile their videos. So I show this to my patients. They like the fact that they have reference. They can go to the Facebook page, the YouTube page, and learn something from there. So I tell my students, you can't give what you don't have, so you have to learn first. And the same applies for young doctors starting. You have to learn it in order for you to share it with your patients, with your colleagues, or even with your fellow, with yourself. Uh, Again, as I said, you learn to teach, but then you later on you teach to learn. So the nice thing with our field is that the operative data is readily shareable. The machine records what you're doing, the actual surgery going on, and it's digital. And with some editing, you can actually share it to the patient, can ask the patient's permission, and share it online. That's a big plus already. Not many surgical fields have that advantage, and not many doctors have the time to document what they're doing. Okay, spine endoscopists, as I've discovered in our community, are very generous people. They like to share. Not even COVID stopped us. COVID was raging throughout last year all the way to this year, and people were having webinars, conventions online, and for free even. People were joining, were discussing about things. Experts were popping up here and there to lend their ideas, and it's very nice. I've never seen a community of doctors as very vocal and as very generous as this. So that's a big advantage for us. Okay, moving on, obstacles, pitfalls to possibly starting a practice in spine endoscopy. This is a big one. I encounter this with a lot of the hospitals that I try to present this technique on. The hospital will say, "Oh, we don't have the equipment for that, or we don't have the staff for that." They're always negative. They say, "Oh, it's experimental. We can't do that here," and they don't know any better. So I tell them it's actually not experimental. It's a lot easy to set up if you really know what you want to do. You're willing to teach. So the dictum here is buy what you can in terms of the equipment, use what you already have, and for everything else, improvise. This is a picture of a tape dispenser in one of the nurses' stations where I did my first two spine endoscopies as a private practitioner. So this is a very clever hack. Uh, the thing is, when I first got introduced to this, I learned how to use the osteotome. This is the BESS kit that Dr. Choi was using. Muscle dilator, everything. It's all there, but it's expensive. It's about 600,000 pesos. So I said maybe we can buy the similar equipment for much less, and still be able to do what this does. And true enough, yes, you can. It costs a lot less, and you can still do the things that you need to do with it. Of course, later on, I ran into another problem. What if I don't have a radio frequency ablator? What can I do? I learned that you can, since we've all been using bipolar cautery probes, you can actually use the bipolar cautery probe if you modify it like this. You can use thinner and thinner wires, and you can set the gap, however big you want it. It works. It's just not as fast as an RF ablator, but I've been using that for my practice. So a hospital might say, we can't do the surgery here. There's no RF ablator, there's no RF machine. You don't need that. The bipolar cautery will work just fine. Okay, this is a newer modification. I saw this when I stayed with Dr. Park in Korea. Your standard uniportal cautery probe. Okay, they of course this is disposable. So when they dispose of it, I took some of the disposables, I cut it open, I repurposed it, I designed it to be used for UBE. And you'll see the tips, the standard tip, and then you can actually modify the tip if you want to. They work just fine. They work just the same. Very useful. And it's thinner, it occupies less space. Okay, what if you don't have burrs? A lot of us use burrs now. Before I started using osteotomes, now I like using burrs. This is expensive again in the Philippines. Not many hospitals have this. So I've adapted to using power drills for orthopedics, except that it's a bit tiresome because you have to hold the drill like this. You can get the drill bit of an arthrosome used for knee arthroscopy. If it's brand new, you can just cut it, fit it in a drill, a battery powered drill or an air powered drill, and you can use that if you're just starting and you don't have this equipment. What about this? Is, of course, a big thing. The hospital says we don't have an endoscopic tower. How are you going to do endoscopy? Not a problem. There are very cheap but very good endoscope cameras and scope sets. You can buy them. It plugs into a computer like your laptop. Some models plug directly to an LCD TV. So you can actually be doing arthroscopy on a 50-inch screen and you never need this. This is a battery powered light source. It will last for about 2 to 3 hours. So very useful. And with that, when I bought that, I actually started practicing. I said, I don't have access to a cadaver, and I can't just practice on patients. So where do I practice on? You can actually make your mock-up set. Very easy to do. You get cadaver bones, you pin them with K-wires, an orthopedic thing. Pin them on a piece of wood, put them in a canister like this. Fill it with water, put the cover, put 2 holes, and then start doing your burring. There's no soft tissue, yes, but at least you get the feel of having to do the bone work. So it's beginning practice for somebody who wants to gain more proficiency. Of course, if you have a simulation lab, all the better. But for me, this is what I started with. You want to order sets, they're expensive. Maybe you can order them piece by piece, going on eBay or Amazon or something. So again, there are workarounds to the obstacles. The elephant in the room, very big question that I keep getting from patients and fellow doctors. Is your technique effective? How do they compare with what the other doctor is doing, like open fusion or tube-based microdiscectomy or something like that? So I tell them, well, I said I wasn't going to discuss so much of the detail, but I will provide the link. I hope some of the people in the audience will try and access my Google Drive. I've been collecting recent journals on everything on endoscopy, including uniportal endoscopy. If you want to download this from here. I hope you take a screenshot or contact me if you want me to share this with you. There are so many studies. The studies keep coming, and a lot of them clearly show the advantages of going endoscopic. So sometimes I feel like this: I'm offering a new technology to someone. I'm offering a round wheel to someone using a square wheel, and people keep turning me down, thinking that what is that? That's something new, but we can't use that. Hopefully, the attitude will change over time. Okay. We have shorter hospital stay, which means again less exposure to infection, which means that the patients and staff feel more reassured. It's more affordable surgery. More patients can avail. This is usually a fear of the hospital. Your surgeries don't cost a lot, so how can we make money out of it? How can we stay afloat? Well, we can do more surgeries, so we can regain whatever you're thinking might be lost. More availing patients, then it's a win-win for everybody. The doctor wins because you get to do the surgery. The patient wins because you get the treatment without having to spend much. And the hospital wins because you're going to get more cases, more patients coming in. Okay. That said, some ending words. I'm winding down, actually. Work smarter, not harder. Okay, you can tailor fit your work cycle, your protocol, so that you don't have to spend so much energy. Doing endoscopy is working smarter because actually you save yourself from a lot of trouble. You save your patients from a lot of trouble. Okay, expect resistance, especially if you are in a country like mine, wherein this technology is not well known. The problem being that everyone's a skeptic, or people are so used to the old ways, the current techniques, that they're not willing to try anything new. So in reality, when I started out, I thought it was going to be like this, but it's actually more like this for me. But that's okay. The challenge is there. I usually say this, that it's only impossible until somebody actually does it. And just last October, I remember showing one of my very first thoracic biportal endoscopic spine procedures in Dr. Gustilo's Zoom conference. And one of the experts said, you can't do that in a small hospital, because that was my topic. I said, doing this surgery in a small hospital setting. He said, you can't do that in a small hospital. But I just did. It's a small hospital, it's government, there aren't that many perks. But we have an endoscope tower, and I brought all the other equipment, and the patient was there, and I successfully did the decompression for thoracic myelopathy, and the patient's happy. So if I can do it there, imagine what we can do if you had everything at your disposal. But yes, you can do it in a small hospital setting. Okay, so this is the time for a spine endoscopy. One of my favorite quotes: "What is necessary is never unwise." People, there are detractors and critiques, people who will criticize the technique, but I think a good idea proves itself, and endoscopy has been proving itself since how many decades now, and it's just getting better. The technology is getting better. The techniques are evolving, and eventually, hopefully, people will come to accept this as a very good alternative to other techniques that we've already had. So I'm not saying that we will remove all the other techniques in the past, our fusion surgeries, our open surgeries. We will still probably need to do that, but this is another thing that we need to learn if we are to become to maintain our relevance and advance in the future. So with that, I hope you enjoyed the presentation. Thank you very much, Professor Nasser, for this invitation. Thank you to Endovision for uh, putting me in the team, and I hope we can do more sharing in the future. And to the audience, thank you for your attention.
Thank you very much, Henry. It was a great talk, really, and it was one of the most interesting presentations about endoscopic spine surgery. Now we open discussion for a few minutes, panel discussion, because in the chat I don't have any questions or comments, but I would like to ask our other speakers, distinguished speakers, if they would like to make any questions or comments or discussion with Henry.
Yes, Dr.
Pistonji, welcome. I know that you joined late a bit because there was a problem in connecting. Do you like to make any comment to Henry?
Dr. Henry, it is my pleasure to know you and see you today personally. Wonderful talk by you. You come from the school of one of the best masters of UB, that is Dr. C.W. Park. He's one of the leading lights of South Korea. He's a personal friend of mine, and it is my privilege to interact with you today. Despite all your difficulties, you are planting the flag of UB in the Philippines, and that is a wonderful thing to see you do that way. We are quite amazed at your adaptations, your struggle, and I hope that you keep on doing better and better in the future. That is my wish and desire for you. So God bless you. It was a fantastic lecture.
Thank you. Thank you very much, Pistonji. Sigdam, do you like to make any comments or questions to Henry? Sigdam, would you unmute your mic?
I really impressed him. I'm really impressed him. Thank you so much, Dr. Henry. I don't have any question.
Thank you, Sigdam. Omar?
Yes, I would like to forward my congratulations to Dr. Henry for this nice journey during his career and his journey through the endoscopic procedures. and it's actually a good innovations for beginners who are struggling like you, and quite great congratulations for you. Thank you.
Thank you, Omar. Now we move to the second speaker, Dr. Sigdam Mumku. She's a neurosurgery specialist, Sultan Bey State Hospital, Istanbul, Turkey. She's going to speak about patient safety in biportal endoscopic spine surgery. Sigdam, are you ready?
Yeah, I'm ready. Hello again. I will present to you about patient safety in biportal endoscopic spine surgery. UBE, that means unilateral biportal endoscopy, is elegant and fantastic endoscopic technique in the spine surgery field. However, it is technically difficult, especially for neurosurgeons who are not familiar to arthroscopic equipment. So the surgeons need to be trained specially to learn manual skills. We know that there's a considerable learning process, and it takes a long time actually. Your team is paramount. There are lots of details to prepare before starting the UBE. That means your nurses need to know how to set up the water pump of the irrigation system, or how to connect your video system, and so on. It's not only a surgeon who must be trained to manual skills, but also your team, your nurses, your technical staff. That is why I recommend not just for you as a surgeon to be trained, but also for your team for the success. When you start UBE, we recommend you to operate with easy discectomy cases at the level L5S1, which has interlaminar window that is much wider as it gives you much maneuverability. Later on, start with discectomy on the level of L4-5. When you have more practicing, then you can do it lateral recess decompression. And when you get more practicing with using bird, you can start spinal canal stenosis. And then finally, you can perform with posterior foraminotomy in the cervical spine or far lateral discectomy. You will gain enough experience in your first 50 cases. For patient safety, operative preparing is very important. We perform UBE under general anesthesia because general anesthesia is more comfortable for the patient and for the surgeon. The patient is prone position with open up the operating table in order to widen interlaminar window. This makes the surgery a little bit easier. Also, especially 5 to 10 degree head-up position is necessary to protect optimum eye speed during the surgery. In microscopic surgery, some surgeons use Wilson frame to make kyphotic posture to widen interlaminar space. Hypothermia posture may increase epidural pressure. That may lead to more epidural bleeding. We recommend using neutral rolling pad. That is the key. We use a special fluid collecting bag, and we make skin marking under C-arm. What are the operative steps? Skin marking is basic for UBE. Two portals must create a triangle, which is very important. We clear upper lamina, interlaminar space, lower lamina from soft tissue by dilator. And also it's essential knowing how to use irrigation system for fluid control, clear view and bleeding control. When you prepare in interlaminar space, following step is similar to open microdiscectomy or microdecompression. In this, you can see on C-arm picture triangulation, created triangulation. If you lose anatomic orientation, the procedure becomes a little bit risky. We always need to know exactly where we are. We need to have full orientation. If you feel free are getting lost at first, you must convert to microsurgery. When you finish your surgery, always you should always put Minivac drain for bleeding control to all patients. After first day, if it is clear, we remove it. Post-operative first day, patient is fully mobilized and MRI must be taken place. Patient is discharged. Post-operative wearing brace is necessary for 3 to 4 weeks. I'd like to mention about my UBE cases. I've been doing UBE for 2 years. Till now, I've done 244 cases. I faced serious complications in the beginning, such as bilateral visual loss, paraspinal infection, incomplete complete decompression. I had an epidural hematoma. I had to turn to open surgery for 5 cases. By time, I've learned how to avoid complications. Now, I'd like to share what I learned with you. What are the things to avoid for patient safety? More muscular damage, high hydrostatic pressure, and RF damage, joint violation, dural tear, cord injury. More muscular damage can cause muscle edema, so it may lead to infection. Please keep in mind. What is the cause critical damage? Surgical view must be clear to get good result. To have good vision, you must handle closely. The scopic hand is always movable, therefore you are able to go more deeper. That is the vital. If there is bleeding, move scope much deeper. You can benefit from suction tip like a natural drain is as inserted here. Then let fluid and blood exit, or you can use Bomax sometimes. High hydrostatic pressure can cause all these complications. CNS problems, long-level epidural hematoma, massive abdominal fluid collection, or hypothermia. What are the CNS problems? One of the most serious complications is the visual loss due to retinal hemorrhagia. Other complications are posterior neck pain, headache, if long time OP with dural tear, late awakening, hydrocephalus, pneumocephalus, seizure, blindness due to retinal bleeding. What is the theory for retinal hemorrhagia? Rapid epidural fluid injections cause a sudden increase in ISP. The increase in ISP pressure causes an increase of retinal venous pressure. Then retinal vein ruptures, which result in retinal hemorrhagia. I had a case one like this. The patient is 28 years old man, suffered from low back and right leg pain due to L5-S1 disc herniation. He underwent UBE surgery for L5-S1 by irrigation of 30 millimeter mercury of normal saline. There was no dural injury or any complication during the surgery. Post-operative, a few hours later, he had visual loss bilaterally. I was shocked. He was immediately referred to the Department of Ophthalmology. He had bilateral retinal hemorrhagia. He was applied YAG laser in the both eyes. 1 month later, his visual acuity increased and the hemorrhagia were remarkably resolved. Optimal pressure must be 30 to 50 millimeter mercury in OP field. How to control optimal hydrostatic pressure? As I said before, first, patient must be in head-up position. Second, always we have to control output. For this, the nurse holds the UBE retractor. Continuous output is to prevent complication. How to control bleeding during UBE? Systolic blood pressure should be 100 millimeter mercury, usually epidural when bleeds. When active bleeding, you can do direct coagulation with RF device. If doesn't work, you can use bone wax or gel foam or wound cloth. If you don't know where the focus of bleeding is, close the irrigation fluid and wait just 2 or 3 minutes. Clotting will happen spontaneously for bleeding control. Then you can restart. Sometimes you can put epinephrine 1 ampoule to irrigation saline. Hypothermia is to prevent the infection, the operative window should be wide. All fluid must be drained outside of the body. If we use small operative window, fluid enter the abdominal surface. Also, long time surgery gets abdominal surface wet, which causes hypothermia. How to use RF? Use RF probe together with Grenache tube. It's important. And use RF short but repeatedly. RF probe power should be outer ligamentum flavum area. Coagulation should be 2. Ablation is 7. On the epidural space, coagulation should be 1. Ablation is 3. Just near dura, coagulation should be 1. And just only you can use coagulation and not couldn't do coagulation, ablation. What is the theory? Coagulation RF device. What is the working principle of RF device? Coagulation technology is a relatively new technology. It uses radiofrequency energy to excite the electrolytes in a conductive medium such as saline solution, creating energized plasma. This discharge plasma produces chemical active radical species, which breaks molecular bonds, causing tissue dissolution at low temperature, approximately 40 to 70 centigrade. That is the working principle of RF device. We must use RF probe with Grenache tube for heated fluid. What is the Alif damage? Low temperature. Sometimes we can see low temperature burn or direct neural injury, maybe cauda equina syndrome or severe paresthesia. How to prevent Alif damage? Direct touch on dura of lumbar spine is relatively permitted, but on cervical it isn't. Avoid touching directly on dura of cord level. Short and repeated use. Avoid touching directly on dura. Elevate by hook. Then you can fire. How to prevent infection? To be careful is gold standard. We should prevent contamination of instruments, irrigation fluid, drip sheet, and serial dilators and tube. This is my patient. She is 42 years old. She had left leg pain during 6 months. I did UBE surgery 1 year ago. This is preoperative MRI. She had left L4-5 disc herniation. This MRI is post-operative second days. Her pain was gone after UBE. The patient was discharged post-operative 2 days later. But 5 days later, she came to my hospital. Her severe leg and back pain and contraction. You can see there is a hyperintensity zone, this paraspinal area on the MRI. At that time, I did open surgery. When I cut fascia, all prudent infection material came out. She undertaken antibiotherapy for a long time. This MRI is 2 weeks after second surgery. Now she is doing fine. She has just moderate back pain. I want to show you my short video regarding how to perform UBE. Please enjoy. You can see surgical view is clear, and during the operation there is no bleeding. Success in UBE with no patient complaints depends on being careful regarding this all details. Many thanks to my great mentors, Dr. Hayati Aygün and Dr. Son, and thanks to Mustafa Bulut, who is head of the Sultanbeyli State Hospital, to set up and split out of UB in Istanbul, Turkey. Thank you very much for listening to me, Dr. Nasser.
Thank you, Sigdam. It's really an enjoyable talk and very good presentation, and you have very good experience operating on 240 or 244 patients. Really, I think you are raising this specialty in Turkey. Let me ask you how many neurosurgeons or orthopedists in Turkey are doing this procedure?
Just one neurosurgeon, 2 orthopedists.
In all Turkey, okay, and the one neurosurgeon, it's you. That's right.
Just me, right?
Yes. We are proud of you, Sigdam, really. And now we open discussion. I'm very happy to have an intelligent woman in neurosurgery from Turkey, and she is experiencing and mastering this procedure with very good results. Now we open discussion. Let us first have questions from the panel. I have 2 questions, and they already joined the panel now from the chat panel. Mariam Ghanem from Egypt. She is specialist neurosurgery from Azhar University. Mariam, are you here?
Yes, Dr. Nasser, I'm here.
Okay.
Hello, Dr. Sigdam. Hello, Dr. Sigdam. I would like to thank you about this grateful knowledge in your presentation. I would ask about MRI post-operative. It is mandatory to do it for all patients, or when patients show clinical improvement, we cannot do it.
I couldn't understand.
Sigdam, she is asking if you are doing magnetic resonance imaging for all your patients routinely post-operative, or
yes,
only
routine.
In some patients?
No, all patients.
All patients.
I check to MRI post-operative one day. After one day, I check MRI all patients, to all patients.
So what is the value for MRI post-operative? Check the workout or what? For what we do it post-operative?
Sigdam, she says why you are doing MRI routine in all your patients.
Collecting my data.
Just
yeah.
Yes,
Yeah.
Okay. Okay. I have another question, if you never mind.
Yes, of course.
Cervical disc prolapse, the site of incision, and what's the approach?
Paramedian approach.
Sorry again, can you repeat?
Paramedian approach.
Yes, okay. Okay, paramedian.
Yes.
Yes. Thank you.
You're welcome.
Thank you.
Thank you, Mariam. Any other questions from the audience? I think somebody raised his hand. Awad, Muhammad Awad from Ain Shams University. Can you listen to us? Do you want to share in the discussion? He was raising his hand. Okay,
unmute him. Unmute him.
He's unmuted. He can mute himself. He is now in the panel. Okay, we now open panel discussion with all our speakers. Henry, do you like to say any comments to Sigdam about her lecture or any questions?
I just wanted to, I wanted to comment about the post-operative MRI. That also gets asked sometimes of me, or do I need to have a post-op MRI? Being in orthopedics, we're in the habit of doing imaging before and after, before, during, and after surgery. The only setback I can see is that in the Philippines, it's quite expensive to get an MRI. But we try to talk to our patients beforehand and to tell them that you've had your MRI before the surgery. I would want to order another one after the surgery just to be able to show you what happened also.
Right.
Most patients will agree to that. Or if an MRI isn't available, at the very least, CT scan with 3D image reconstruction.
Sigdam, do you like to respond, or Henry, you finished your comment?
Yes.
Okay.
Ahmed Hassan raised his hand.
No, wait, Omar, wait until we finish the panel, and then we go back again to Ahmed. Pistonji, do you have any comments or questions to Sigdam?
Definitely. She is my favorite Turkish neurosurgeon in UB. Wonderful lecture as usual, Sigdam. Honest, straight from the heart. Discussing one's complications on an international forum is a very great thing to do. We have a lot of take-home messages from you. One is regarding fluid pressure. My one suggestion to all upcoming UB surgeons, and I think even to you, Sigdam, is try and finish all your bone work before you open the flavum. That way, on the open dura, you have less and less pressure. As you are outside, you're working, finishing all your bone work extra flavorly, because that is the one thing that I'm now trying to develop. I'm even trying to do contralateral lateral recess, contralateral foraminal stenosis, SAP tip osteotomies. Everything I'm trying to do now, I have changed my own tack, and I'm trying to do everything extra flavorly, trying and preserving as much of flavum as possible, as long as possible. See, our natural tendency as a UB surgeon, what is it? We first go in, we find the U. When we start doing our side laminectomy, we come to the flaval laminar junction, then we start stripping. And we open up the dural surface. Try not to open up the dural surface. Let the flavum be there. Try do sublaminar decompression on the opposite side, keeping the flavum. So once you keep the flavum, once you get used to it, it's a little bit of a struggle. But once you get used to it, you will do all your bone work, all your contralateral work, sublaminar decompression, ipsilateral decompression, everything extra flavorly. Flavum is the last thing that you separate, and then go straight for the disc. So that way the fluid pressure on the dural surface remains for the minimum amount of time. You will have less bleeding problems. You will have controlled all the bone bleeding before you have even reached the dura. So before you expose the dural surface, before you strip the flavum, finish all your bone work. That is my one suggestion to you. That will help you avoid many of your complications. That you deal with your complications intelligently is fantastic. Avoiding them is even better. Avoiding them is even better. So that is one comment for you. And lastly, one small comment. You are my daughter's favoritist neurosurgeon, and she wants to be a neurosurgeon. So you are the inspiration. Thank you. Wonderful.
Thank you. Thank you, Pistonji. Thank you very much. And really, it was wonderful work and wonderful presentation. I think what Pistonji said now, it's very important. Always try to keep the ligamentum flavum intact to avoid any complications. This is for teaching purpose for all young neurosurgeons. It's very important advice or recommendation from one of the masters of endoscopic spinal surgery. Omar, do you like to say any comment about Sigdam presentation?
Just to congratulate Dr. Singh for her honesty to raise the issue of her complication. And this is the most important issue in medicine. When you raise the complications, you will teach yourself, and you will teach better the others. All we learn from our and other complications. We are not obliged to do all the complications to learn, just to learn from the our colleagues' complications, our own complications. And this is a very good chance for audience to learn how to do a safe endoscopic surgery. Great, congratulations, Dr. Singham. Thank you.
Thank you so much. Thank you.
Thank you, Omar. I think we have a question. Ahmed Hussein, do you like to say comment before we move to the next speaker? Ahmed, are you here?
Yes, hello, Dr. Nasser. Hello,
Ahmed,
Dr. Omar.
introduce yourself, please, and then start speaking.
I am Ahmed Hussein. I am a lecturer of neurosurgery, Qasr Aini, Ahmed Hussein. Dr. Nasser, I need to ask about at the end of the operative video. I guess the doctor put a drain through the incision of the endoscope, or she didn't put a drain. I think I saw something like a drain or something
Yes.
like this.
Signam, do you like to share the video again so that we can see it?
Okay, okay. Share the video.
At the end of the video.
Yes, there is a drain. Yes, that's right.
Yeah. So you routinely put a drain after the procedure, or?
Yes, yeah, routinely.
Maybe it's a good chance to see the video again.
Ekran paylaşımı.
If I may make a small comment while she's showing the video.
Yes, of course. Please, Pistonji, go ahead.
In my entire series of UBE, I do not put in a drain. But in South Korea, there was an incident where one patient developed a severe epidural hematoma that led to severe cord damage, paralysis, and subsequent death of the patient because of other complications. Now, because of that, and because of certain other governmental pressures, it has become mandatory, at least in South Korea, that whatever you go near the spinal cord, you must put in a drain. And actually, I would definitely even advocate it. I will definitely go by what Dr. Shidam is doing, because we never know post-operatively if the patient bleeds. There should be a way for the blood to egress and rather than create internal pressure. So though it's not absolutely mandatory, and though I personally don't do it, because I'm very confident of control of bleeding, which I achieve. For all young neurosurgeons, all upcoming UB specialists, I would definitely advise putting in the drain. It's better to be safe rather than to be sorry. And the drain can be removed comfortably within 12 hours or within 24 hours. So it's not really a big thing, but it's like, it's like a safety valve. So definitely encourage it for all upcoming UB surgeons. Definitely encourage it.
Okay. What about you, Henry?
Before, sir, when I started doing this, I would not put a drain. But after my training in Korea and after seeing what they do, I put a drain for my patients and remove it in 24 hours.
Okay. Omar?
For me, on 1,500 cases, I didn't use drain at all. And my concept, I think, the bleeding when it occurs with the endoscope is not from the surgical procedure. That's the surgical procedure of the endoscope is quite gentle, quite very minimally tissue trauma. I think the bleeding comes due to bleeding tendencies, bleeding errors in the patient himself, not from the surgical procedure. This is my concept. I didn't have, hopefully, I didn't have any post-op bleeding or hematomas or epidural hematomas at all. Hope.
And Sigdam, you leave the drain routinely in all your patients post-operative?
Yes, I always put drain post-operative.
Okay. Ahmad Hussam, you finished your comments?
Yeah, thanks, Dr. Nasser.
Okay, keep joining us, and now we move to the next speaker. Our next speaker is Dr. Malcolm Pistonji. He's one of the well-known endoscopic spinal surgeons. He is practicing in Mumbai, India. Thank you, Pistonji, for contribution to this webinar.
Unmute yourself, please, Dr. Pistonji. Unmute yourself, please. Dr. Yes, now it's okay.
So, I'm starting my lecture. Here we go. Yeah, now my basic talk upon is a true transforaminal facet sparing lumbar interbody fusion. We normally, when we talk about TLIF, TLIF is a word that's actually a misnomer, because TLIF basically signifies, okay, you're going transfacetal, but does not signify that you're destroying the entire facet, you're removing the entire facet. So you are actually creating instability to then put in a cage, try and achieve fusion, then put in rod screws and try and achieve stability. So one thought that came across the mind is, why not develop a pure transcambin fusion, which is facet sparing, which will be very effective and a safe way. And if you can do it under local anesthesia, then the patient is not required to do any neuro monitoring. Patient is monitoring himself. Patient is awake, aware when I'm putting in a cage, and it's a very easy way to do it. So that was the ideal quest. I mean, quest is, how do I do something which is most ideal? So we started with, like I explained to you, it was a misnomer, it was creation of instability. And what happens if there is a non-union? It's not necessary that every time you do a fusion procedure, you have an achieve a union. Sometimes there is non-union, implant failure over a period of time, subsidence of the cage, and then you are left with an iatrogenic facetal loss, subsidence, breakage of implants, and a whole series of complications. If I can avoid destroying the facet, then I have an additional safety barrier. So that was the concept. So I'll just play this video of mine. Good morning, welcome to Golden Park Operation Theatre, Endospine Suite. Today we are doing a case of transforaminal endoscopic spine fixation. We'll be introducing the cage through the foramen without violating the facet, and we'll be doing minimally invasive posterior screw fixation with reduction of a patient of degenerative listhesis, as you see over here. The L5 is moved ahead on the S1. There is collapse of disc height, and you can see that in extension there is partial reduction of this, but in a flexion view, you can see that it's a grade 1 to grade 2 listhesis. Now, if you see here in the MRI, you can see there's a huge broad-based disc bulge because of the listhesis. It's a very tight foramen. Bilaterally, patient is having severe claudication. There are wet facets that are observed, thickening of ligament flavum, but basically the sac size is quite capacious. So I feel that by getting a good distal height transforaminally and minimally invasive fixation and debulking this posterior discal surface through an inside-out approach, we will be able to restore this spine to its normalcy. This surgery is basically being done under local anesthesia, where the entire cage will be inserted under local anesthesia to the patient. And subsequently, after patient is given a sensory epidural, we will be putting in with local aided 4 minimally invasive screws. The top 2 screws will be reduction screws, and we should be able to fix up her spine with the cage loaded with bone graft from the iliac crest. And hopefully she should be on her way to recovery. So thank you very much. Let's hope we get a good result today. And now I'm going to show a video of the C-arm images of graft preparation. Or rather, you can say the graft site preparation. We need bleeding bone, both plates, superior and lower end plates. So yeah, what we are doing now is we are curating the end plate. Okay, This is just show you the external visual, and now I'll be showing the CM images. So over there, you'll be able to see the movement of the curate, how it moves within.
Mr. John.
Unfortunately, it's not an edited video, so sometimes the voice becomes a little louder. And now you'll be able to see the CM images of what I'm doing.
Give me a live shoot, please. Continuous. Yes, thank you. And as you can see, continuously shoot. Hena, John, please. As you can see, we are now creating entire space inside.
I'm working on the lower end plate right now.
1 minute, please hold steady now. No, don't shoot now. 1 minute. Shoot, please, John. Yes, now you can see that the curate is bent.
I bend the curate to increase its arc and sweep in removing the discal material.
Wait, please, John. Shoot, John. Only single shoot. Single shoot. Single shoot. Shoot, John, live, shoot, cut. Yeah, now you can see.
I'm curating away at the superior end plate now.
We're creating the center of the disc. Okay, thank you so much. Stop shoot.
So this was the slide. And now you can see the internal scopic view. You can see the bleeding end plates.
Stripped.
Completely stripped away.
Now I'm rotating the tube.
Now you can see both the end plates. Both the end plates are in your view now. You can see the dural surface above.
Surfaces are now prepared.
Some more of the graft muck is being removed.
There are a few loose fragments which are being pulled out, flushed out, and we are ready to place our cage.
In this video, you will see how I'm introducing the cage. This is a cage guide which is locking into place now. I'm removing the dilator out completely. This cage guide has got an extra long tang that as it goes into the center of the disc, it dilates the Camden's triangle to a height of 11 millimeters. Here I'm introducing a 10 mm cage. And you'll be able to see the cage now. Yeah, I'm asking the patient to move her legs. She's nice and awake. Now she'll be moving her limbs.
Wonderful. Is she having any pain? Shoot, John. Shoot, John.
The cage is now finally going in place.
Shoot, John. Okay, any pain, ask her, please.
There are two things to consider here before I play the next video. Is one, it's an L5S1 disc. So obviously the angle of approach is a little downwards. It's not a very flat approach, especially if you're going transforaminal. And after sitting in the cage, what happens is that if you leave any fragment in the contralateral corner of the disc, opposite disc corner, sometimes the placement of the cage pushes a fragment out of a tear in the opposite side. And once or twice in my life, I've encountered this, that whenever I put in a single TLIF cage, a larger cage, then the patient lands up with sometimes a small herniation of a disc on the opposite side. It's a rare phenomena, but if there is an annular rent over there, nuclear material can get pushed out. So I prefer to do another thing. I prefer to do a contralateral, again transforaminal endoscopy, and remove all material which is posterior to the cage. Now this is the video of the opposite side, where if you can see my marker, you can see over here that there is a cage over here, and I'm working on the opposite side of the cage. What you see above is now the annular surface.
That has been inserted from the opposite foramen. One can see the entire annulus which has been de-roofed and decompressed. There is no material, annular material or nuclear material posterior to the cage now that can be retained and be a cause of pain. So biportal endoscopy with insertion of cage in one of the foramens.
You have the option of introducing another cage also from the opposite foramen, but I chose not to because I put in a decently large cage. My experience has been with degenerative retrolisthesis, lysoslisthesis, severe lateral canal stenosis, wherein I want to get an additional disc height where there is a lot of disc collapse. So this was the case with retrolisthesis where we have put in a cage, done our fixation. You can see the cage is being introduced from the left side here. This is another patient, same video over here. I will play it once again, but this is at the L4-5 level. This is not at the L5-S1 level. L5-S1 level, we are a little sloped. Here we are more transverse. Sorry. What you can see over here are the 4 small cuts on the skin. This is small cut for removal of the graft. And this is from where my endoscope had gone in. So truly minimally invasive. You can see that we have put in a decently large cage. We have fixed it up. And this is the patient. She's visiting me on her 10th day post-op. Walking around in the lab.
Okay. This is Kalpana. She has undergone a facet-sparing transforaminal fusion with the cage and 4 minimally invasive screws. She has got a bifocal endoscopic discectomy at the same level to remove all distal material from behind the cage, which is possible in an oblique positioning of the cage. The other issue that she had was a disc at a higher level, for which again she had undergone transforaminal discectomy. Today is, I think, the 10th day follow-up, and she's walking comfortably. We are very happy to receive her today. Namaskar, sir. Thank you. Hello.
So we will discuss now the advantages and disadvantages. Advantages that I preserve both the facets. I have a cage insertion under local anesthesia. The second stage epidural anesthesia for only missed screws and rods, which is only sensory, does not need to have to be motor. Patient does his or own neural modulation and minimal invasive blood loss less than maybe even 50 cc's. Visualized end plate preparations. Zero accidental durotomy because you're not even seeing the dura, you have retained the entire posterior annulus. So there is no question of even the cage moving into the dural canal. And it's ideal for elderly patients with multiple comorbidities. Now, what are the disadvantages? Disadvantages, you cannot do this procedure if the patient has severe central canal stenosis because then you need to do in a UB, you need to do a UB TLIF. There is no other solution to that. Expensive infrastructure, endoscopy is definitely an expensive thing. And you need endoscopic training. So like Shidan said, you really need to train. What David says, you really need to train and you really need to train. There is no shortcut to that. So that is the disadvantages of this. But I think the advantages far outweigh the disadvantages. I have a nascent series of only around 22, 23 cases, working more on it. Hopefully we'll be publishing some good results. So I thank you all on behalf of my university and myself for this patient appreciation of this lecture. So I shall stop screen share now. I hope you all have enjoyed this lecture.
Dr. Nasser, thank you, Dr. Pistonji. It's a very nice work using this very minimal invasive technique, especially for fusion. Is there any questions from the panel about these techniques? Dr. Henry, Dr. Zigdam, anyone has any questions?
Thank you, Pistonji, for this great talk.
Thank you so much, Dr. Nasser.
Now we open discussion from the panel. Henry?
I can't comment yet. I haven't done an endoscopic fusion. Perhaps later, sir.
Do you have any experience about the procedure Pistonji is doing?
The only T-lifts I've done are the mini open types, wherein you do a Wiltshire approach, do a total facetectomy. I've actually done both the bilateral instrumented fusion and unilateral fusions, but I've never done a fusion endoscopically. So that's one other thing on my list. I want.
All I can tell you, Henry, is that it's very easy. One just needs to get oriented with transforaminal endoscopy, and basically it's a very, very, very safe thing to do because the patient is awake. The slightest of pain on the nerve root, littlest of tingling numbness, or littlest of heaviness, and you know that you're causing pressure on the root. So when I introduce the dilator, when I introduce the guide itself, if the patient can tolerate the guide, patient tolerates the cage. It's as simple as that. Moment your guide goes in, you are dilating the disc space by a millimeter. If the patient has any pain, if patient has any discomfort, you are going to know immediately. Now, this is the advantage of doing something under local anesthesia, because you have total control. While when we do UB T-Lif, or when we do even open T-Lif, God forbid if something happens and there is traction on the root, you wake up and you realize that patient has a foot drop. Story is already over. Then you're waiting for recovery, and then you're giving steroids and all those, everything has its own plus, everything has its own minus. With this particular procedure also, there are some minuses. The minuses, like I explained to you, okay, expensive equipment, slight difficult learning curve, little orientational issues in the initial part. Like how should I mention, okay, when you are lost, shift to open. It's as simple as that. Don't struggle when you're not oriented. But as you do a few 100,000 cases of endoscopy, then it becomes a little difficult to get disoriented. Somehow you're always oriented. So that is a little advantage of things. But doing it under local anesthesia, doing it with the patient completely awake and aware, moving her limbs at every stage of the surgery, you are assured that at the end of the surgery, your patient is going to really walk home comfortably. So that was a plus, and that is why I've been working on this. Along with me, Dr. Koichi Sario from Japan, he's also working on this. So let us hope we can, come out with some positive results and some positive publications. Transcameron wise, I have only one problem which I've encountered is, and be very honest, is that I have not yet gone beyond 11 millimeters in cage height. While with Olif, with Alif, you can go up to 13 millimeters cage height. But somewhere I feel that argument doesn't make sense, because 10 millimeters, 9 millimeters, or 11 millimeters, as long as you attain sagittal correction and as long as you have enough disc height and enough freedom of the root, there is nothing that says 12 millimeters is better than 11 or 13 is better than 11. I mean, I feel eventually the result is what matters. Patient being pain-free is what matters. And patient not really suffering the surgery is what matters. It's how you deliver the whole package. So with even 10 millimeters and 11 millimeters cage heights, which I have used, I found more than adequate satisfactory results. So I feel that is the bottom point of things. Endoscopically, if I feel, this is just a little point beyond the scope of this talk, is that transforaminally, it is also possible to knock out the tip of the superior articular facet to create more space if one wishes to create more space. But then that is again playing around with the facet. So if you want to really preserve the entire facet, especially in patients with retrolisthesis, degenerative listhesis, then I feel that this approach of mine really holds great ground. If anybody has any other comment or question to ask.
Dr. Nasser, unmute your mic. Dr.
Yes.
Nasser. Dr. Nasser,
I'm sorry,
unmute your mic.
I'm asking Sigdam if she has any comments about lecture of Pistonji.
Yes, I wonder how many cases do you have, dear Malcolm?
How many?
How many cases do you have like this?
I have done a series of about 22 cases now, Shidem.
Oh, sorry, what?
I have done only 22 of these cases.
Oh, okay. What is your... I got it. Thank you. What is your... one more question. What is your serious complication during this surgery?
The serious most complication that I had was a little bit of a root dysesthesia, persisting numbness, because when I was finally seating my cage, last tap, patient complained of numbness in the thigh. But I checked the motor power was okay, numbness was there, and definitely I got a little scared. I gave the patient 125 milligrams of methylprednisolone shot, one shot, and then one more repeat shot at 4 days, and that sort of settled it. But that was a bit of a scare. That was the only complication I had. Otherwise, I'm actually waiting for my fusion results.
It's very important, yes.
I'm waiting for the fusion results, whether I've achieved proper fusion or not. And that is the only reason why I've not published my series yet.
Sorry, how long have you been doing this procedure?
The last 1.5 years.
Wow, good. Thank you.
I think Sigdam may change her opinion and she go to India to work this procedure with you too.
Yeah. I think so.
She is a daughter who is always welcome.
Yes. Thank you. I know.
Congratulations, Pistonji, and I'm very happy about all the lectures today are great. Now we move to our last speaker, Professor Omar Youssef. Omar, are you ready?
Yes, thank you, Dr. Nasser, for this kind invitation, and thanks for all our eminent speakers and colleagues. Is it okay?
Yes, it's okay. Just start the data show. Maybe it's slow, but it's going to work. I know that you are working from the mobile or laptop?
No, laptop.
Okay.
Now it's okay.
No, it's not working. We can see the screen of your computer.
For me, it's okay. That means the net is slow.
We can wait. We can. Yes, now it started.
Already now?
I think it started, but it doesn't show any image. But it's full screen data show.
I'm sorry. I think the net is a little bit low. I don't know why. Not yet till now, not yet. With me, it's clear now.
No, we couldn't see the image.
May I do it again or what?
Yes,
or
I think you have to go out and start again.
Okay. Sorry for this delay.
Yes, now it's perfect. Now we can see.
Okay, now?
Yes. Just start the show. Yes, now it's working.
Okay,
Go ahead,
thank you.
Omar.
Thank you.
Thank you.
Quite sorry for this delay. My talk today, it's in the same context of the endoscopic procedures about the challenge of the minimal invasive spine techniques, endoscopy in cases with lumbar spine radiculopathy. We have to differentiate between the minimal invasive surgery and the minimal surgery. This picture it shows a minimal surgery or a low profile surgery. This is not a minimal invasive surgery. Why? The minimal invasive surgery should and must have a special criteria. The first one must have a minimal access to the target or to the pathology. The second criteria is a minimal tissue trauma, and the most important, it must achieve a maximum cure. If this minimal invasive technique doesn't achieve a maximum cure comparing to the other techniques, this means this is not a minimal surgery. This is not a minimal invasive surgery. However, this is a minimal surgery or it is a low profile surgery. Is a very important point. The endoscopic spine surgery, I classified either a basic techniques or an advanced techniques. Here, this model shows how it looks the basic techniques using the interlaminar lumbar pharomotomy or discectomy or pharomotomy with the discectomy as well. The other advanced techniques, first one is the uniportal 1x2 reaching at 2 levels through only one port. I use one port and just changing the shaft of the endoscope along the vertical axis under the image control. Then I could reach 2 levels through only one port. This is why this technique is quite versatile technique and it's quite feasible to do this approach. The second one is to use it as a biportal for two non-adjacent segments. For instance, level L12 with L45, I use two separate techniques. The third technique is the use of the uniportal the third technique is the use of the uniportal bilateral endoscopic laminotomy. Here, the concept is to go through only one port, reaching both ipsilateral facet and the target, and in the same time the contralateral. All these I could reach it from only one port through changing the shaft and the axis of the endoscope along the horizontal or transverse axis. Through this, you could reach both ipsilateral and the contralateral. The fourth technique, to use a uniportal to reach 4 targets. To use this for 2 levels canal stenosis or 2 levels foraminal stenosis, and by this technique, using only one port, reaching 2 ipsilateral sides and 2 contralateral sides. This is a quite versatile technique which deal very safely and perfectly with different pathologies. The fifth technique is the biportal bilateral for 2 levels. Here we could reach 8 targets, 4 ipsilateral targets and 4 contralateral targets. This is could reach it through when I use adjacent two levels. I could adjacent 4 levels. I could reach these all 8 targets through 2 nearby ports for endoscopy. The sixth one is to use a uniportal skin incision, then a biportal muscle or fish incision, and bilateral especially and only in cases with huge central disc and impending coda equina syndrome or impending paraparesis. This is the only indication for this technique. I used it for only, I think, one patient only. The seventh technique use the posterior interlaminar endoscopy for recurrent cases reaching to the normal bone, then creeping to reach a normal dura. And the eighth and the last one, to use the endoscope for recurrent cases for 2 levels through only one port, changing only the axis of the endoscope and reaching 2 adjacent levels and dealing with 2 recurrent levels through only one port. I use my techniques on about 1,500, but now is more than 1,500. I did a classification criteria for my patients, criteria 1, criteria 2, and this is the third one till now I am following. Here you will find I exclude only cases contraindicated for general or spinal anesthesia. My work is most of cases I work using the spinal anesthesia. Any cases, sorry, any cases contraindication for general or spinal anesthesia is excluded for endoscopy, or cases with instability, or cases with right canal stenosis with disc. Those cases I exclude from endoscopy. The others could be feasible and could effectively, properly done by this technique. By surgical technique, the patient is in a prone position with a spinal anesthesia. The entry points between 1 to 5 millimeter of the midline, using the image, C-arm image, and working either on the vertical axis or the transverse axis. Why this technique is versatile? Here, when you look here, this is the uniportal interlaminar discectomy for 2 levels through only one port. As you see here, go through only one port, changing the axis of the endoscope, reaching 2 adjacent levels with a good control, with good and proper effective removing of the disc from all parts until we make sure that the root is become free. There's another one here example how could use this technique for 2 levels, for 5 1. This is the MRI pre-op, and this is the video clip showing the procedure itself, going to the ipsilateral unilateral level, then shifted to the second adjacent level with the same technique, doing a good discectomy, pharmacotomy, and the end of the surgery. We should make sure that the roots become free, the pre and post of MRI and the wound incision. This is the only case where I use the uniportal biportal bilateral endoscopic laminar discectomy. As I said before, she was a student, 18 years old, with this quite huge central disc, and this is she has impending coda equina syndrome. I went firstly from the ipsilateral side just to evacuate the disc and decrease the pressure inside the disc space. Then through the same skin incision, however, through another facial and muscular port to other side to evacuate the contralateral side, as you see here, with total disc evacuation, and still satisfying till now. There's a quite interesting case. It was 65 years old lady. She complained of back pain, and she did a laminectomy surgery outside my country. However, the MRI is quite normal. I don't know why the surgeon did this surgery. But the patient, when she came to me, she was deteriorated with a quite paraparesis. When I examined her, it was an upper motor neuron lesions, not a lower motor. That's why I did an MRI. And interestingly, I found dorsal 8 angioma, and I did another MRI for the lumbar spine, and that I could found here a recur is a huge disc. Although he did, the surgeon did only a laminectomy, I found here a huge lateral disc. That's why I did endoscopic discectomy for this lady. In the same session, microscopic excision of the meningioma, as you could see from this clip. It was in the same session. I started firstly with the dorsal meningioma. Then after I finished, I went down to for the endoscopic discectomy, as you see here, removing a huge disc. That's why I consider this technique quite versatile technique, could deal very properly and very effectively with a different lesion and different pathologies. Sorry. Sorry for this corruption.
Omar, do you have any problems?
Yeah, I don't know. There's here hang on of the computer. I don't know why it didn't proceed. What's it? Yes, now it's working now.
Yes, yes, it works now.
Mhm. Okay. Sorry, actually, sorry for this corruption. Is it working with you, Dr. Nasser?
Yes, yes, we can see now.
I'm actually sorry for that. Actually,
No,
sorry.
no problem, no problem.
Does it work, Key? Does it work now?
We can see the screen, but we couldn't see the video. It's loading. It says that it's loading.
Only load.
Yes, it says that it's loading.
I'm so sorry. I'm so sorry.
It takes time because the internet is slow.
Maybe this is the problem. Now it's working or not yet?
No, Omar, I think it downloaded, but it's not, still it's not, it's working, but very slow. It's working, but it's very slow motion.
I will stop video just to accelerate the net. Working now?
Yes, it's downloading, it's working, but you can speak like this.
Okay.
It's slow, but
Okay.
it's working. It's working. Okay.
Okay.
It disappeared again.
Oh, now it's working, right?
Okay, yes.
Okay, I'm so sorry. I'm so sorry.
It's working now.
This film show this a large anterior epidural disc fragment amalgamated with the dura anteriorly and with the root, and it shows how with this technique how you could deal very properly and very effectively to remove all these large fragment, and which it was a very quite difficult. It was amalgamated with the wood and amalgamated with the anterior dura, and you could see here how I could deal with this quite large fragment and located anteriorly epidural to the coda, and that's why I, I, I could call this technique a quite versatile technique, as it could deal very properly with a different types of pathologies and different types of discs. Another example here shows a quite huge, large epidural fragments here 4, 5, as you can see here from the MRI and from the video clip, how the coda is quite humbled and quite elevated, and it's quite very strange. It was more than 10 big pieces and fragments of disc materials. You will see how I could deal with these fragments under the endoscope, and how I could see properly the coda, and how I could preserve the coda and preserve the roots with the advantage of this technique and with the advantage of the endoscope. And you could see still there is a residual and more residual fragments. All these are an epidural fragments. That's why here I try to make sure that the disk space is free, and no more fragments inside the disk, or no more fragments in the subligamentous area. Now there is finishing this case, we could see here more than 10 big fragments of disk. Another case was huge recurrent disc in a patient underwent 2 previous open surgery. These is the pre and post MRI, and plain X-ray shows how the bone is preserved, and this image shows the difference between the 2 skin incisions, the first 2 open and my endoscopic incision, and you could see here also how it was a very quite big recurrent disc fragment, and this why this technique it's quite versatile technique, as it deals properly and effectively with a different difficult cases as well. These show a different examples of recurrent sorry. Show examples of different cases of ruptured discs, how the endoscope deal very properly with all these different cases. The first one, the right disc is quite adherent to the shoulder of the root, and the other one is in the subligamentous area in the interdiscal space, and the third one here below, it was subligamentous recurrent after 1 open and twice endoscopic techniques, and after the end of the surgery you could see the root is quite free without any more fragments. Here it show how I could deal with the endoscope and with this technique to deal with the adhesions in a recurrent cases, or if there is a disc fragment at the shoulder and the other on the axilla of the root. It shows here how I could deal with it properly. Here these adhesions quite tight, and now it's released, and go now to see the root, or to see any residual fragments. This another example of a patient 70 years old, had a previous wide extended laminectomy. However, he had a huge 3-4 disc, as you see here. And from the endoscopic picture, this video clip show how it was a big fragment. Imagine how it was quite big, and how I could remove it safely and properly by the use and the advantage of the endoscope. It's quite big fragment here. Now this is still another fragment in the disk space itself. I try to remove another fragments. I have to navigate in all direction to remove any residuals. However, this patient developed discitis. The ESR was 160, and this is the post-op pre-X-ray to show the same stability, no other further instability. 2 weeks post-op, this MRI show a collection, looks and like infection or abscess. He followed for a long period of antibiotics. This is the MRI 4 months post-op. The collection start to partially resolve it, and this is the last after 6 months antibiotic post-op. Patient now is quite moving well and satisfying, and this raised the issue of that there is no 100% successful approach or 100% successful technique ever. Any procedure has its drawbacks, has its complication, and there is no procedure could solve all the problems 100% effectively. And this example of a long period of follow-up till 12 years follow-up post-op with a quite good decompression, good ischectomy. This is show in cases with the use of uniportal bilateral for a 2 level and for a canal stenosis 2 levels, how I could reach both the ipsilateral for the 2 levels and another 2 contralaterals. That's through only one port I could reach 4 targets. And this is not only, I could deal also as well with any associating disc, as you could see from here. Removing the disc and the laminotomy of the both 2 ipsilateral and laminotomy of the 2 contralateral sides. And this the post-op CT shows the good decompression in the 2 levels. This is a very interesting examples how this technique is quite versatile, using the uniportal bilateral laminotomy for the both ipsilateral and contralateral. And this first film here, you could see how I could remove the disc from the contralateral side very effectively, and seeing well the contralateral facet and the contralateral foramen from only ipsilateral uniport. The others show how to deal with 4 levels. Here, this is a 4 levels biportal, bilateral through a 2 portal endoscopic ports, reaching an 8 targets, 4 ipsilateral sides and 4 contralateral sides. And we could see how the coda quite decompressed properly, and how the dura looks free now, and how the roots, all the roots looks totally free. And here, this is the third one also, how you could see here the roots and the dura totally decompressed. Here there is a little bit bleeding. I put just using the batty and control bleeding, then doing a discectomy associated with this case. That means you could deal with different pathologies in the same port with without any problem, and quite properly and effectively. These another examples. Just to save time, this like the previous one. Here, just to raise the use of the HD camera. It's quite important, especially for the beginner. There is a quite difference in the brightness, in the resolution, in the image. It's quite helpful for the beginners to differentiate and delineate the different neural structures from each other. And now, in the last 5 years, I'm using actually the high definition camera, HD camera. It added a lot for me with this good, brilliant images, better images, better high quality resolution. You could delineate all the structures from each others. Complications. As I said, there is no procedure without complications. The first one developed intraoperative dural tear, but with a good experience, you could deal and continue the procedure, although there is a dural tear. Here you could see the roots. It's starting to appear outside the dura. Here I use continue to do the discectomy, and the second one here there's a multiple dural tears. That's why using the patty to prevent the widening of the dural tear, then shift to the do discectomy with the other hand, one hand on the sucker on the patty to control the tear, and the other hand using the scalpel open the disc, and then using the disc forceps to remove the disc materials as well. This patient has no CS fleek. I put a gel fat graft and then gel foam. However, he developed a moderate size pseudo meningeal intramuscular pseudo meningeal, and the first one went very non-eventual procedure with non-eventual any complications. This table shows the different complications I faced in my series. I had no cystic leak at all, and this is due to that the wound of the endoscope is quite narrow, and the muscle is quite healthy, and the fascia is quite intact. This make like a tamponadic effect on any bleeding or on any CSF leak. I had 0% of CSF leak through 1,500 cases. Discitis will occur in only 5 patients. Weakness, temporarily and partial deficit in 0.7% of the cases. Recurrence occurred in 10 cases out of the 1,500 with 0.7% of cases. I follow the modified ranking scale. My cases had a grade 0 with 66% and grade 1 with no significant disability with a very mild symptoms in 32% of cases, and grade 2 with slight disability in only 8 cases, 0.5%. Why the posterior internal endoscopy is a quite versatile technique? Because it's feasible for all types of disc, lateral disc, caudal migration, rostral or cranial migration, epidural, subligamentous, 2 levels or 4 levels, and all the complications are curable and comparable to the other techniques. My conclusion: the posterior endoscopic internal technique preserves the motion segment, which is the most important issue in spine, and it is, I think, it's the most versatile technique as it offers a one port for 2 sides or even 4 sides. It offers a one port for 2 levels. It deals quite well with a multiple pathology simultaneously, lumbar canisters with a facetal hypertrophy, with disc prolapse, with the hypertrophy of the ligament flavum, 2 or 4 sides, 2 or level. All these multiple targets and multiple pathologies, you could deal with it perfectly in the same time without any other new incision or new ports. It offers a shorter hospital stay and rapid return to work. it avoids the use of implants in a recurrent disc, and this means a cost effect benefit, and in addition, it avoids the adjacent segment disease after fusion. The complication, as I said, it's quite few, comparable to other approaches, and curable. My word or my message is that all MES techniques are essential. Don't stick to one technique. You have to learn all the MES techniques. Learning care is very essential. To my mind, the endoscope is a magic instrument. It could opens unexpected new fields in front of the surgeon. Spinal endoscopy, it's a real practice. It's not an imagination at all. Uh, as you see, this is the workshop we did all over these years. We hope this pandemic ends soon to continue our scientific activities. And I have this chance to announce for our near upcoming cadaveric course on May 23 to 28 under the auspice of the Egyptian Society of Neurological Surgeons, and the number is quite limited for 10 only due to the restrictions of the COVID. I would like to thank you, and I would like to forward my apology for this corruption of the net and the computer. Thank you very much for all of you. Thank you, and I'm sorry.
Hello, Omar. Thank you very much for this great talk.
Thank you very much, and I'm sorry for.
And now we open. No, it happens with all of us sometimes, and now I think we have some discussion. If we open discussion about panel, we start by Henry. Henry, any comments about talk of Omar?
Sir, I actually cannot imagine doing those. You do a lot of MIS techniques and a lot of approaches. I've never tried using the tubular retractor, so I'm trying to imagine it as an endoscopic technique for the most part. But those are very difficult surgeries.
Okay, Sigdam, any comments for Omar?
Just I thank to him for a great presentation. Yeah, I didn't have any experience this surgery.
Okay, Pistonji, can you hear me? Do you have any comments or questions for Omar? Any questions in the chat panel? Anybody of the audience would like to make any comments?
I have only one comment or advice that no fear from any dural tears, that somebody afraid from tears and they had to turn the endoscopic procedure to open. The dural tear during the endoscopic surgery, it's quite dichotomous, and even when you have a tear, just to put dural graft and just to put multiple layer of gel foam, it would be effective, as the wound is quite narrow, quite small. It will act by its tamponading effect.
Mr. Omar, could I ask a question?
Yes, please, Mariam, go ahead.
About dural tear, you put a fasciolata graft on lay technique, not sutures. That's what I understand. This is right or not?
No, just a small fat graft, and then on lay layers of gel foam, 2 or 3 layers of gel foam. It's quite enough,
For
quite enough,
supporting.
quite enough.
Yes, yes, okay. Another question about ipsilateral or contralateral. You mean we're using posterior midline approach, not paramedian approach?
No, it's a paramedian. I use a transverse incision starting from the midline to 16 millimeter of the midline. And for this, I could reach 4 targets for even for especially for 2 levels and for 2 ipsilateral and 2 contralateral.
Yes. So it depends on practice, not a solid indication or contraindication. How can I reach the contralateral side?
It depends on what? Sorry?
That's right. It depends on practice, on skills, surgical skills. How can I
Yes,
reach
this
the
is.
contralateral side?
That's why I said there is a basic techniques
Yes,
for. I said there are a basic techniques for beginners,
yes,
and there are another advanced techniques. And don't jump from the basic to the advanced. You have to
advanced.
master the basic firstly, and then to the advanced. If you're interested, please join our next workshop. You will see these cadavers by yourself.
Yes, okay. Thank you. Thank you.
Thank you. Thank you.
Mariam, do you have anybody from Azhar University? Mariam is working as specialist in Azhar University. It's one of the biggest university hospitals in Cairo. Do you do these procedures, minimally invasive spinal endoscopic surgery in Azhar?
Recently, it began in Al-Zahra University Hospital for about 2 years at least. But I have no experience about endoscopic lumbar surgery.
Okay. By anybody would like to add any comments? Henry, Sigdam, before we close the webinar?
Professor Omar, I just wanted to ask regarding the disc infection. If the infection goes into the disc, do you like put a drain in? If you have to come back and do a debridement or flush, do you still put a drain?
No, I didn't use a drain at all, neither for hematomas or neither for infection. The case with discitis, I followed just only antibiotics and the rest, and you will find the percentage of the discitis quite low. Why? The whole procedure there is a lot of fluid, a lot of fluid irrigation. That's why the endoscopic procedures is doesn't introduce infection. Only few percentage. It was due to a bad sterilization of the instruments only.
Thank you.
Thank you for the question.
Thank you, Omar. At the end of this webinar, I would like to thank all our distinguished speakers. Thanks to all of you for contributing to this neurosurgical activity. All the presentations were great, and I hope that we can gather again in another occasion soon, not only in webinars, but in person. We are organizing courses in Egypt, me and Omar and all our colleagues in different subspecialties and in spinal endoscopy too. It will be my honor to invite our speakers for our next meeting or next activity in person, which can be done in Egypt. Hopefully, after this pandemic is going to be terminated, we hope to gather all together soon. Let me make an important announcement that next Friday at the same time, at 2 p.m. Egypt time, webinar number 35 among our series of webinars. This webinar is organized in collaboration with the World Federation of Neurosurgical Societies. It's a WFNS educational symposium about pediatric neurosurgery with about 10 faculty. They are masters of the pediatric neurosurgery worldwide from different continents. The flyer available on the website of the World Federation. Registration is required because last webinar was booked out before being started. Thanks to all attendees for joining us. Thanks to all of you. Thanks Henry, Sigdam, Omar, Pistonji, and all of you. And thanks to organizing team who worked much with me, Ahmed Magdi and Dr. Hassan Ala. And thanks to all of you, and see you again soon. Thank you.
Thank you. Bye bye.
Thank you very much.
Thank you. Thank you.